Tamer, I think we'll try to present in 10 minutes if you can.
Okay.
Okay.
Okay. Let's go. Welcome in Hurghada. Welcome. This is the kickoff the Cardio Risk 24. Diabetic CKD, we new in science in 2022. We are going to call DKD. Okay. This is our objectives today to know the diabetic nephropathy in the 21st century. The diabetic DKD is common. According to NEHAN's participant, we have in patients more participants with estimated GFR less than 60 and more with urinary albumin to creatinine ratio more than 30. And despite improvements in care, still we have increasing incidence of the DKD. The presence of DKD plus cardiovascular disease equal more hospitalizations and more mortality. Diabetes is becoming now a non-proteinuric state in the United States, and the rate of albuminuria is decreased for these patients. The prevalence of DKD in type 2 diabetes has increased over the last 25 years. And a substantial percent of the DKD is now non-proteinuric, about 48% non-proteinuric. There are many risk factors for the DKD, for older age, more for men. There is hereditary forms, there is systemic conditions associated with DKD, like hypertension, obesity, hyperglycemia. There is kidney injuries, like AKI, toxins, and smoking, and for diet, high protein intake. And there's two classifications of DKD, according to the glomerular lesions or according to the vascular and the tubulointerstitial lesions. And the start will be the glomerular hyperfiltration will initiate the DKD. The SGL2 with high capacity and SGL21, high affinity transport glucose in the nephron, and there is an important role of the renin-angiotensin-aldosterone system. And there's an association between the aldosterone inflammation and the incidence of fibrosis. So what are the standard of care of DKD in 2022? The aims is securing the diagnosis, cardiovascular risk reduction, and renal risk reduction. And the objective is to go with glycemic control, blood pressure control, keeping in mind the presence of cardiovascular disease and renal disease, and initiate and sustain evidence-based pharmacological service. The diagnosis of DKD depends on impaired estimated GFR less than 60 or albuminuria with urinary albumin creatinine ratio more than 30, and annual screening for DKD every 5 years in type 1 diabetes and at the time of diagnosis of type 2 diabetes. Individualize your glycemic control. Overall, we can target to be less than 7% without significant hypoglycemia, and we can use continuous glucose monitoring to keep the patient more than 70% in time and less than 4% out of control. You can go with hemoglobin A1C less than 8 if there is severe hypoglycemia, limited life expectancy, advanced microvascular complications, or long-standing diabetes. What is the role of kidney in glucose homeostasis and how to avoid hypoglycemia during intensive glycemic control? Kidney shared by gluconeogenesis and by reabsorption of the filtered glucose by the proximal tubule, and insulin is cleared by the kidneys. And this is the anti-diabetic according to ADA. The FDA label change for metformin in diabetes and CKD in April 2016. We should measure estimated GFR before starting metformin. If less than 30, don't initiate. If between 30 and 45, we should reassess the risk-benefit ratio, and we can discontinue this metformin when we use iodinated contrast, especially if patients have a GFR between 30 and 60, liver disease, alcoholism, heart failure, or use of contrast. And after the use of contrast, we should evaluate after 2 days, and if the GFR is okay, you can reinitiate metformin again. What about the blood pressure goals? There is a conflicting guidelines. For KDIGO, ADA, and ASD, it is 130/80. For the GNC8, ESH, and ESC, it is 140/90. Why is this conflicting? data because the data driven by lack of efficacy in the ACCORD trial, and there's a higher renal adverse events with intensive therapy. We should use single, not dual RAS inhibitors, ACE and beta and ARBs in the diabetic kidney disease. We should lower the cardiorenal risk in patients with CKD and type 2 diabetes. The presence of urine albumin to creatinine ratio is the best prophet of renal risk in the renal study, and the presence of residual albuminuria and albuminuria delta after use of ARB predict bad kidney outcomes. The association between cardiovascular outcomes, heart failure, and kidney disease trials tell us this is the time to use SGLT2 inhibitors. SGLT2 inhibitors reduce all-cause and cardiovascular deaths by about 15%, reduce the MACE by 10%, heart failure events by 30%, and reduce the rate of end-stage kidney disease by 37%, and the composite kidney outcome of worsening kidney function and end-stage by 39%. So the renal benefit is SGLT2 inhibitors is observed irrespective of the presence of diabetes or not. The aldosterone MRA for the reduction of cardiorenal risk across the spectrum of DKD, the effects of phenylenone can reduce the loss in the estimated GFR and modest effect on the blood pressure. So, do the MRA and SGLT2 interfere with each other? No evidence of effect modification based on the limited and subject to selection effect post-hoc subgroups data, no interaction between the two groups. How to manage hyperkalemia that may occur in patients going for a RAS blockade MRA, which is associated with more incidence of hyperkalemia. There is more options to use. You can measure potassium before start. You can stop RAS inhibitor if there is an increase in hyperkalemia temporarily. We can preserve the kidney to get rid of potassium using diuretics or SGLT2 inhibitors, and we can use potassium binders as a management. The role of GLP-1 receptor in diabetic kidney disease is proved with use of dulaglutide, liraglutide, and semaglutide. And to take our home point from this section, the patients may be selected for further therapies based on testing the urinary albumin to creatinine ratio, which is simple, cheap, and very effective in guiding us to more manage or further manage our patients. SGLT2 inhibitors have a broad cardiovascular, renal, and heart failure benefits. The effects of SGLT2 and on chronic kidney disease don't differ between it is diabetic patient or not. Successful rule out of the SGLT2 inhibitors is likely to have the same population level effects that the ACE and ARBs had. Selective MRAs have the same effects on the cardiorenal outcomes as SGLT2 inhibitors, and you should manage patient well when you use combination between these drugs. And to wrap up in this last minute, the DKD nephrology encounters in 2022. Number one, establish the absence of a non-diabetic lesion. Initiate and optimize and sustain evidence-based pharmacological therapy, whether use ACE inhibitor, ARB, SGLT2 inhibitor, MRAs, and guideline-directed medical therapy utilizing the urinary albumin creatinine ratio and presence of albuminuria to select the patients for further therapy. What to do with a non-proteinuric DKD who can impact kidney, prove the role of SGLT2, and it is stopped early for efficacy. You should treat the complications like hyperkalemia with using diuretics, potassium binders, SGLT2 inhibitors, the volume overload, the CKD complications, the hypertension management is important, and to consult a referring physician about the renal safety and efficacy and dosing of anti-glycemic therapies, whether metformin, SGLT2 inhibitors, GLP-1 receptor agonist, or DB4 inhibitor. And thank you. I'm
thank
sorry
you,
I go
Tamer,
rapidly because of time, okay?
Yeah. Thank you very much.
أوامر
Tamer.
الرئاسة يعني.
I know you are not a nephrologist, of course.
Yes. بس
Neither
أحمد هو
me.
اللي خلاني النهارده على
However, proper assessment of renal function is very important.
Yes.
Sometimes we find a patient with relatively low eGFR. This low eGFR may be from kidney disease or may be secondary to hemodynamic burden of left ventricular dysfunction, HFrEF, HFpEF, ischemic myopathy. So it's very important to use the urine albumin create ratio and albuminuria in the proper assessment of renal function in order not to deny the patient important medications that may help his heart. Of course, you will refer the patient to a nephrologist if you think that there is pathology in the kidney, but we have at least to know the simple methods to properly assess the renal function of the patient.
Yes, we are assessing the risk of the patient, of our patient, which is cardiac patient. We know what is the real risk of this patient, whether for the renal or kidney level, for diabetic level, plus the cardiological level. And the use of sample tests may further increase the risk of patients to take care of some medication that may have a precaution, some combination between drugs to proceed with, and sometimes you need to refer for a nephrologist to conjoint with you to adapt your patient. You should know the GFR for your patient to adapt your cardiac drugs, which drug to use below 30, below 20, below 45. This is important for you to adapt the management of your patient before the nephrologist proceed for managing the kidney problem or complications.
Very important, exactly. What dosage of what medication? Thank you. Anybody has a quick comment or a quick question? Professor Tamer is here. Please, quick question, quick answer, because we're running short of time.
Thank you, Dr. Tamer, for the nice presentation. My question about the use of statin in diabetic patients. We know that diabetic patients should take statin.
Yes.
The presence of DKD make you select a specific statin, maybe atorva or zuva versus another one?
Excellent question, excellent question. The everyday debate, okay? From the last point, the contraindication to use statins is to initiate statins for patient going for dialysis just for dyslipidemia. Even if the patient if have acute kidney syndrome and go for dialysis, go with a statin. This is the first issue. Statin is class 1A with the chronic kidney disease. And with going up to level of 3, grade 3 and more, there is a class 1A. This is a high or very high risk patient, and you should give high dose statin and go to the target. Which drug to use? The most studied drugs in the kidney or renal patients is atorvastatin, well studied. And when we go with rosuvastatin, there's a concern about the dose. They tell us don't go more than 10 milligrams. This is the recommended dose. What is actually the best drug? We don't know, but studies are more with atorvastatin, well-studied drug, okay? And there are another drugs like pitavastatin. Pitavastatin have improved the GFR about 5.4 in one study, 5.4. And the atorvastatin and rosuvastatin, there is some decrease with time in the GFR. So there is a new data coming now with more studies on statins on the renal patient. But it is highly indicated, don't stop your statin in patient even going to dialysis. He was on dialysis, he was on statin, continue it. And the presence of acute coronary syndrome, forget the kidney, go for high dose statin and adapt the doses and drugs accordingly.
Okay, thank you, Dr. Tamer. Thank you.